So now I'd like to introduce our moderator this evening, Michael Scott from Prostate Cancer International, to share with you more about Prostate Cancer International's organization and introduce our wonderful speakers this evening, Dr. Charles Ryan and Dr. Alicia Morgans.
Thank you very much indeed, Jamie. It's my great honor this evening to introduce two people who've probably forgotten more about castration-resistant prostate cancer than most people have ever learned. They are both medical oncologists. Dr. Chuck Ryan, who was formerly at the University of San Francisco and the University of Wisconsin, has just been appointed the new Chief Executive Officer and President of the Prostate Cancer Foundation. And you may have questions that you want to ask him about what he thinks PCF is going to be doing over the next couple of years. That will be fine. Alicia Morgans has just moved from Chicago to Dana-Farber in Boston. I have to say she is one of the most patient-sensitive medical oncologists it has ever been my pleasure to meet. And so thank you very much, both of you, for being here this evening. We're going to be talking about the workup of patients with castration-resistant prostate cancer and the implications for their treatment. And please go right ahead, and I will butt in if I feel I need to. But thank you so much for being here this evening, the pair of you.
Well, thank you very much. It's Mike, it's a real pleasure. I'm glad you invited me. I remember very clearly you and I sitting spontaneously next to each other having breakfast in Basel, Switzerland a few years ago. And I think that's probably the cause of how this invitation arose. So be careful who you eat breakfast next to, I guess is one way to think about it. I'm really happy to be joined by Alicia, who I think many of you know. She and I have done a number of programs like this together over the years and have collaborated on research projects. And I would have to agree, one of the most patient-centric and most clearest voices in our field. So when I was asked to do this, I thought, well, I sometimes mumble, so I'm going to ask somebody to join me who speaks clearly all the time. And I also thought it'd be really fun to just have the two of us have a dialogue and just kind of talk through this, how we think kind of as we walk through the workup of patients, because you'd probably forget a lot from a lecture. But I think when you hear people talk about the pros and cons and the debates and things like that, that might be kind of nice. I'm going to give Dr. Morgans a minute to introduce herself, talk a little bit about what she's doing at Dana-Farber, and then I'll have some slides that I'll put up, and then we'll start the riff back and forth. Alicia, good to see you.
Good to see you too. Thank you for the invitation, and thank you so much, Jamie and Michael and everyone. Really just wonderful to have the opportunity to speak with everyone tonight, and feel almost like we're in Ohio, even though we don't go anywhere anymore. And I do hope that you can safely have your in-person meetings at some point soon. That sounds really rewarding. And I think that that's one of the things that we hope to have in a cancer community, certainly as yours is, and what we're hoping to continue to build and strengthen at Dana-Farber. So I moved there this summer and have taken on the role as the medical director of the survivorship program across all cancers, actually, adult cancers, not just GU cancers like prostate cancer. But really, I think the main focus at this point, since it's been such a short period that I've been there, is trying to elevate the care of men with prostate cancer throughout the course of disease. From the moment of diagnosis, we're survivors with cancer. And I think that we deserve to have everything that we can, everything that can be put in place to make us have better lives from that moment forward when we come into contact with the cancer community. So very happy to be here today and to talk more specifically about how we approach the thought process and the workup and the eventual treatment of men who have more advanced prostate cancer, metastatic castration-resistant prostate cancer. And so thank you for putting up the slides. I'll pass the virtual mic back to you.
All right, thanks. So I'm really actually excited to be asked to talk about this topic for a couple of reasons. One reason is that it's changing very rapidly. And two is that it is a situation we have where we are getting more and more information. And then the question is it good to have more information? Because it's not always the case that when we get more information, we know exactly what to do with it. And that's a dilemma for patients, and it's a dilemma for the doctors. And the third reason why I'm excited to talk about this topic is that because it's a dilemma for both of us groups, this is an opportunity for you as patients to help your doctors help you better by pushing for tests and helping to help them interpret their tests for you. And I think that what I mean will become clear as we go through this. So I'm going to show just a couple slides, and I'm going to start with the definition of how do I do this? Hold on. The definition of CRPC, and this is a really old slide that I've shown forever. And I first want to tell people that, there's 200,000 men in the United States diagnosed with prostate cancer every year, actually 200 to 230,000. And there's about 30,000 men who die of this every year. So there are a lot of people who get diagnosed with prostate cancer who not only don't die of it and never will die of it, but they die of it, but they're not at risk for dying of it. And then you want to talk about those patients who do face the life-threatening form of this disease. And it's really the confluence of two events. It's what we call castration resistance. And I show it here in a graph I made many, many years ago, which is when the testosterone is down and suppressed and the PSA begins to rise and the cancer has spread outside of the prostate. And for this disease to be a lethal problem for somebody, both of those events have to occur. And we're going to talk today about how you define those things. We're going to talk today about what we know based on how we define them, and a little bit about what we do in that context. So I'm going to go to the next slide, and I'm going to ask Alicia, this is an old-fashioned bone scan. And, when you're in the clinic and you're facing a patient, you're with a patient, his PSA is rising, and he's been on ADT for a while. What do you order, and what do you think when you see a bone scan like this?
Well, a couple things, just to make sure that we're leveling the playing field. ADT is really, it's also called androgen deprivation therapy. And what we are doing with that is giving a medication to try to stop the testes from making testosterone. Because really, I think, and apologies for rehashing what I'm sure you all know, but testosterone is the food or the fuel that drives prostate cancer cells to grow, to spread, to do the things that we don't want them to do, and travel around the body, et cetera. So when we take away testosterone, we're taking away the food that they need to wreak havoc. We're taking it away, and many of them will go into a deep hibernation or die. And that's what we want. We're very happy when that happens. And what you see happening from a patient perspective is that when prostate cancer cells have testosterone, essentially they're eating their food and they're spitting out, or they're making a protein called PSA, prostate specific antigen. That protein is something we can measure in the blood. And so when we take a blood test, we'll see a PSA that's high, because now the cancer cells have their food, they're making their PSA. When we take the food away, we start starving them, the PSA drops. And that's because they can't do their job anymore. They can't make that PSA protein. They stop doing it, they shrivel up, they shut down their factories, they hibernate, or they die. When patients develop this castration-resistant phenotype, and I have to say, I don't love that phrase. In fact, most of us find that phrase frustrating. It is not patient-centric. We've written articles about that, but it is the language that the FDA is currently using to help us understand drugs, and hopefully a name that will change in the future. But it just means when the testosterone level is really low and the PSA starts to go up. So despite there being no food, the prostate cancer cells restart their factories. They start spitting out prostate specific antigen, or PSA, again. So PSA is going back up. So when that happens, we as doctors have to figure out what's going on. We know that the cells are active again. That means there's either more of them, or the ones that are there are starting to be more active, and they could potentially grow or become more. So we typically get scans. And one of those scans, and if you want to go to the next slide, that you had us on is this what we're calling the old-fashioned bone scan. Now, I want to say that it's not exactly old-fashioned. Yes, it's been around for a while, but we are still using it all the time. It is one of the standard scans that we get to understand where the cancer cells might be in the bones. It does not show us soft tissues. Those are things like lymph nodes or the liver, the lungs, or other places, but it can show us the bones, and it's pretty sensitive, meaning that even if there's just a little bit of abnormality, it's pretty good at picking it up. And what we can see in this old-fashioned bone scan, or tried and true perhaps, but the reason we'll talk about why we're calling it old-fashioned in just a minute, but the reason that it's helpful is that you can see these little black spots on this particular bone scan that are in places like the ribs and in the spine. And you can also see that there are two pictures here. This is one person. And what we do is take a picture of the person looking at forward at you, as if you're just standing in front of the person and he's standing in front of you. And then there's one of him from behind. And so you can see that they're labeled on this really nice example of a bone scan. Anterior, you can see his teeth, he's looking at us, and posterior, he's looking away from us. And the reason we have those two images is we can see on the anterior ribs, the front part of the ribs a little bit better. We can see the front part of the pelvis a little bit better. On the back, we can see the spine. And I want to point out too that there's a big black hole where some people think, oh my gosh, that's the prostate. Well, that's not the prostate, so don't worry about that. It's actually the bladder filled with the tracer that we inject. So to get this scan, we have to inject a little bit of dye. The dye goes into the bones in areas where there are cancer cells that are destroying the bones. It also, just of note, goes into areas in the bones that have pretty bad arthritis, and can go into areas that have a fracture, where there's bone that's healing or bone that's kind of inflamed. So this picture, sorry, go ahead.
Go ahead.
I was just going to say, in this picture, if I got this to try to understand what was happening when PSA is going up and testosterone is still low, what I would do with this scan is look at the last bone scan that the person had and try to figure out if there are more black spots on this one than there are in the last one. And if there are, that means the cancer is growing to the extent that I can actually see its growth, see where it is different on my imaging modality. If it's the same, stable, or perhaps even a little bit better, what that's telling me is that the cancer cells are just starting to wake up, and they haven't grown or spread as much as they may. And it may give us a little bit more time to make our decisions about what to do next for treatment. But that's kind of what we're thinking about. We're trying to quantify or understand how much cancer is in there. Is it worse than before? Do we need to make a change? And we often couple this scan with a CAT scan or an MRI to look at the soft stuff, the liver and the lungs and the lymph nodes, so that we understand the whole person. And now I will pass it back to you, and also try to get rid of the cat. Sorry about that, guys. He's come for a surprise visit.
Well, no, that's our CAT scan.
Yes, he is introducing the CAT
Keep
scan.
him around, because when we get to the CAT scan, we need him. So I like to point out that there's a couple of really big problems with the bone scan. Number one, it's not a cancer scan. It's a bone scan. So as Alicia pointed out, arthritis, if you fall off your bike and crack a rib, these are all going to show up on the bone scan. And the reason for that is that the stuff that's injected into your veins before the bone scan is really kind of like calcium. It just kind of goes to bone that's remodeling. It goes to bone that's trying to fix itself. And so that's one deficiency of it. It's not a cancer scan, it's a bone scan. Number two is that the intensity of the lesions, the darkness, does not really reflect all that accurately what's going on. And this is one of these areas where you can help your doctor, or the radiologist at your hospital, because there will be doctors, radiologists, who still, because these are old-fashioned, because those are old, these scans, they will say the lesions on the bone are more intense, reflecting worsening disease. And that's not always the case. The intensity of the lesions can increase if the bone is healing. And so that's a key thing to know. And I've actually corrected some of our radiologists. I said, no, this patient's doing great. And I'll tell you a little anecdote about a patient with a bone scan. Years ago, I had a patient who had a high PSA and many lesions on a bone scan. He goes on hormone therapy. PSA went to 0. And what happened is his doctor locally got another bone scan because he was looking to see if the bone scan got better. His bone scan didn't get better. His bone scan actually got worse because these lesions got more intense. And what was happening is his cancer was going away, his bones were healing, and his bone scan therefore got brighter. Doctor called me, said, this patient's getting worse. I said, what's his PSA? He said, it's 0. I said, your patient's not getting worse. He's getting better. The bone is healing. The doctor didn't believe me. The doctor put the patient on chemotherapy, even though his PSA was 0. Okay. Now, in the long run, it was probably okay for that patient. But the point was that there was a disconnect between what was going on with the PSA and what was going on with the scans. But in reality, there wasn't. The bones were healing. So it's not a cancer scan. It's a bone scan. And then the third point, Alicia already made, I'm just going to state it again, is that bone scans don't really get better. They can, but they don't always get better, even when the patient does. And in fact, when we look at a bone scan, if you are on therapy, we're really looking to see if there are new spots that weren't there before. And so there's really 2 outcomes of a bone scan if you're on a treatment. It's either stable or it shows new spots. And new spots mean your cancer is worse, but stable means it's doing okay. All right.
So there's a name,
right,
in case your doctors name it, that worsening that you can see when we first start a treatment. It's called flare. So if you have ever heard of that, or if you get a scan, you might see, your doctor might say, oh, well, I think this is some flare. And it happens usually when we're starting a therapy as the bones are starting to heal. And sometimes bone scans do get a little bit better. But once the damage is made in the bone, there will be repair in that area, whether there's cancer there or not. So we don't usually see a lot of improvement, but that doesn't mean that the cancer is still growing in that spot in a bad, uncontrolled way. So we really use the blood test, and we use the CAT scan or the MRI, and all of it, the symptoms that a person might be feeling. And we put all that stuff together to try to understand the whole person.
The other thing you should know, and I'll get to this in a minute, is that when we report a clinical trial, there was a trial many years ago that I was part of the team that did it, where we looked at the drug abiraterone and Zytiga, and we looked at how long it took for the bone scans to worsen. And so what we did on that study is we followed bone scans all the time until people developed 2 new spots, and then we confirmed that they had 2 new spots. And the reason I bring that up is that when we report that, when we say the average duration somebody with CRPC is on Zytiga is 17 months, what we mean in most cases is that it's 17 months until the bone scan acquires new spots, because on average, because that was the metric that we used. So when your doctor is talking to you today about a prognosis, how long will the drug work, et cetera, really what we're talking about is old-fashioned bone scans. And so we'll talk about new technology and how there's all this amazing stuff, and I'll show you some really cool pictures in a few minutes. But a lot of the thinking, what we know about the disease and how we make a prognosis, is really still based on these old-fashioned scans, because we've had them for so long, we've been able to follow what happens to them over time.
I just want to mention, though, that a lot of your doctors, if you're being followed for prostate cancer, will order bone scans. Actually, we order bone scans regularly. That is still, it may be old-fashioned, but so is ADT. So is that androgen deprivation therapy.
I'm not saying it's a bad test. Yeah, I'm not saying it's old-fashioned and therefore bad. I'm saying it's just what we've had. And so it's the foundation, it's the historical standard for what we have in terms of our knowledge.
But we still use it. So yeah. Don't take old-fashioned to mean out of date. It is, as you just said, foundational.
Right. Next time we do this talk, Alicia, I will call it the traditional bone scan.
Thank you.
So I put this in because I was writing this. I was thinking, this is we have a lot of new technology coming that I'm going to show you, and more knowledge is usually better in medicine. It's always good to know more about our patients' bodies and their disease and their treatments, etc. But not all new knowledge can meaningfully change what we do, and that is a critically important deficiency and gap that we face as the doctors, which is, we can see a lot more than we could 10 years ago and 20 years ago. But that doesn't mean we have more to offer. We do have more to offer, but it's just a little bit of a disconnect that we have. And I wanted to put that out there because I want to talk about some of the newer things with regards to imaging and scans as we move away from our discussion of the traditional bone scan towards different types of scans. So there are a couple of different types of scans that are coming out, and Alicia hasn't had the opportunity to preview these slides. I apologize to her for that. But I want you to just maybe walk us through your current thinking at Dana-Farber on the new types of scans versus the traditional scans. And here I did use the correct term, traditional scan.
And old-fashioned is still, it's fine. I just didn't want there to be a negative connotation. But because we still do use those scans, and that's why they're on this slide. So if we think about what we're calling, I guess, the traditional scan, sometimes we call them conventional imaging when we talk to different doctors. And it just is a catchphrase that means CTs usually, or sometimes MRIs if patients can't get CTs for some reason, and bone scans, as we just looked at. And we typically get those at the time of diagnosis with either higher risk local prostate cancer to try to understand if that cancer is so high risk that it might have spread outside of the prostate and be either somewhere down in the pelvis area, or whether it spread farther. Or if we have a person who has a very high PSA and we're trying to understand if that person has disease that has spread outside of the prostate and maybe in bones or in some other place like a lymph node or soft tissue like lung or elsewhere. Again, we use the bone scan only to look at bones, and you saw that scan. It looks like bones, and that's because that's all it's able to really look at. And then the CT scans can look at, they do look at bones not as easily, I think, as a bone scan does, but they're additive. They can be used in combination to understand if the cancer's in the bones, but they're really there so that we can understand that soft tissue disease. So that's who, and we do that at baseline when we first meet the individual to try to understand where the cancer is. And then as we start a treatment, whether that's a surgery or whether that's radiation for local prostate cancer that's still all in the prostate, or whether that is ADT or ADT combination treatment or chemotherapy treatment. We do it over time to understand if the cancer is shrinking or growing or what it's doing. And we often time these imaging modalities or these images, these scans, around what the PSA is doing or whether the person has symptoms. New pains, usually we're going to get scans. PSA going up, we often will get scans. And then to comment on I'll let you comment on the new ones, because I know you're excited and that'll be something fun to talk about. But what is the action from it? Well, if the cancer looks like it is growing or spreading, the scans are what we use to quantify that, to understand the extent of spread. We might have to change our treatment, or we might have to start a new treatment if you're not on any treatment in response to those scans. But let me turn it over to you, because I think one of the most exciting things in the last, say, year and a half has been the recent approval of some new types of scans called PSMA PET scans. And I'll turn it over to you.
All right, so I think, Alicia, maybe you can go look at the chat and see if there's any questions, because if there's anybody who has questions about bone scans, before we get too far from them, maybe we could take those.
I will definitely look.
All right, so, when I first was trying to get into medical school, you take organic chemistry, and I thought, oh, one day, I'll be a doctor and I'll think about molecules and I'll be able to draw these fancy, cool, big molecules, and it'll be a daily part of my life. And the reality is, I never do that. But I think this is a really cool molecule to show. And if anybody of you've studied chemistry, you know that these are hydrogens, nitrogens, and carbons. And this is the reason I like this is that this is the molecule that drives one of the tests and therapies that we have that's coming out that's really exciting. And when I explain it in my clinic to folks, I say, this is a molecule that has a Velcro on one side and a basket on the other. And the red is the Velcro. And the structure of that doesn't matter. But what that means is that when you inject this into a patient, that the red part of that molecule will bind to PSMA, which is prostate specific membrane antigen. Doesn't really matter what that is. That's a protein on the surface of the prostate cancer. But then on the other side of this molecule is this basket. And that what you, I'm sorry, I have it reversed. The blue is where it binds the molecule and the red is where it binds, it's the basket. And if you look over that red part where you see the ends, you can almost kind of see that there's this sort of gap in there, this sort of, there's this sort of bed where you can put another molecule. And if you put gallium, which is a molecule that's radioactive, in there, it actually creates an image. And so that's a gallium PSMA PET. You inject this into the patient, the gallium makes this image, all good. But then, same molecule, you can put lutetium, which is another radioactive molecule that we study in chemistry. And if you inject that into the patient, the radioactivity from that little molecule goes the length of this molecule all the way into the cancer cell. And the idea is that it kills the cancer cell. So what we see in this big complicated molecule is actually something that serves as a diagnostic test. So it's part of the workup, and it's also part of the therapy. And that's one of the really, really fascinating things about what we're going through in prostate cancer now. Now, this came from a slide on gallium-68 PSMA PET imaging. Okay, now there is actually an FDA-approved another one called fluoride 18 DCF-PYL, and essentially it's the same idea, where you see this molecule, which on one side binds to the cancer, and then on the other side has a fluoride in this case, and leads to pictures or imaging. And this is a really important, interesting new part of the workup. And I'm going to go to my next slide. I'm going to show you something that's really fascinating. And I think some of you are going to think it's probably a little scary, but I'm going to hopefully make it not scary.
Can you hang on for just 1 second before you get into scary things?
Not scary.
I am just, we just got a question from Thomas, and I don't entirely understand the question, but maybe you can work it out and see if you understand it. I do understand it generally, and I don't mean to, it's a great question. I want to make sure we answer it properly. The question is, why do we have to get a bone scan before a second hormone therapy of 6 months apart? And what I didn't understand is if the if the person had been on for 6 months and everything looked like it was going well, why would we get another scan? Or if maybe after 6 months, it looks like the treatment's maybe not working so well, then getting a bone scan. Maybe you could answer both of those.
Right. So in a traditional setting, if I'm taking care of a patient and he's on hormone therapy, and let's say his PSA starts out at 100 and he has a positive bone scan, and I treat him and his PSA goes down to 5 or 3, I usually don't get another bone scan, because for the reason we talked about earlier, it's only going to cause confusion. If that patient's feeling well, and his PSA is down, the bone scan at that point is going to show healing, and it's going to show brighter lesions. And some people are going to get worried that means that the cancer is worse when it's not. It's rarely going to show worsening of the cancer in that setting. There are some subsets that we worry about, but in most cases, I don't necessarily need that. A CAT scan is a different story. CAT scans are kind of nice to get after somebody's been on treatment, if they have tumors in their liver, if they have tumors in their lymph node, because it is good to see those shrinking. And the CAT scan does reflect that, whereas the bone scan does not. It's a good question. It's a great question. And I think the other thing is that well-intentioned physicians will take different paths here. I don't get bone scans every 3 months in people who are doing well. I have colleagues who do. I just think it puts the patient through another day of, coming back and forth. It's additional cost, although bone scans are not that expensive. But the main thing is I see it as potentially causing confusion. So I usually wait until I have a clinical reason to have a bone scan, or their PSA is rising. What do you say?
I think that's right. I think it's probably to follow up and better understand what's going on. It might be because somebody's looking for improvement, but we heard how that could be a little bit of a risky business. Not that it would hurt you, but you might think that things look worse when they're actually just great. But it might be because there's concern that the cancer might be growing. But in any event, usually our images are to check in and to understand where the cancer is and how much there is, and that is usually the purpose. And the bone scan's looking at the bone. Back to the scary thing, I think, is what you prefaced this as, which sounds really great.
I said you're going to think it's scary, but it's reassuring.
Good.
So we just talked about.
Dr. Ryan, could I just raise a question related to this, which you can probably answer as you're talking about the rest of it? My understanding is that PSMA is expressed in about 80% of prostate cancer patients, but not all of them.
Right.
I'm just interested in you adding that into your
Yes, I
discussion.
will. I will get to that. So that's good. Thank you for the prompt. So PSMA PET, it's really interesting because what's happening now is we have cases where a patient can have a CAT scan or a bone scan that could be negative, and they could get a PSMA PET scan that could be positive. Same patient, these scans could be done theoretically on the same day. One shows no sign of cancer spread, one shows a sign of cancer spread. So the reason I brought this up and thought, well, you might think this is scary is this. This is from the Spartan study, which was in CRPC patients who had traditional scans were clear. Bone scan and CAT scan showed no metastases, right?
But PSA was rising on the androgen deprivation
Right.
therapy.
The point of the Spartan study was to see if we could delay the development of metastases on the traditional scans. Now in Germany, they had 200 patients who entered on the study. So by definition, they had negative CAT scan, negative bone scan. But it was Germany where they could do PSMA PETs. So they went in and they got PSMA PETs. 196 of the 200 patients actually had tumors showing up on their PSMA PET, even though their traditional scans were negative. And as you can see, there are, this demonstrates sort of where things showed up. In 54%, it was patients who had it in the lymph nodes. And then there was a small proportion of patients who had metastatic disease up into the bones. And even a small percent, very small percent, 6% of patients had tumors in the liver or the lung, even though their traditional scans were negative. Now, the reason I say it's scary, not scary, is that these were all patients who felt well, and they were not suffering from these tumors. The reason why it's actually potentially optimistic is that there probably is a difference between that patient who has a negative traditional scan and a positive PSMA PET scan in his bones or in his lungs and liver. And we'll get to that a little bit. And so that is a step forward where we do have more knowledge. But I'm going to talk about some of the limitations of that new knowledge in a second. And we probably will get to the point where we do need to address those patients who are negative on traditional, positive on PSMA PET. The other issue that's really fascinating is that the PSMA is driven. It's also driven more or less by testosterone, and it does seem to track the PSA. So a patient who has a PSA of 0, he could have a lot of cancer, but it's in remission. He goes on hormone therapy, his PSA goes down. His PSMA PET scan will probably be negative. The analogy that I use with my patients is I say, it's like when you fly into Chicago at night and you see the city just goes on forever and it's all lit up. And then that's when the power is working. And then, imagine there's a blackout in the city of Chicago and you're flying in over Chicago and you can't see any lights. The city's still there, but the lights are out. And so with hormone therapy, it's a little bit like you turn the lights out. And so with CRPC, it's like if you're flying over the dark Chicago because the power's cut off and all of a sudden you see some lights starting to come on, right? You know that people are getting the power back. You know that in this case, the cancer is getting its power back. And that's where the PSMA PET might be really helpful in helping us to detect it. But the other point is that low PSA values may have negative PSMA PETs. And that was the root of Mike's question. But I want to get to one other phenomenon and then have Alicia talk to it a little bit. And that's this phenomenon of the Will Rogers phenomenon. So the reason I said scary, not scary, is that the issue is now that we have more knowledge, we can go in and we can do these new scans and we can detect these tumors that we couldn't see before. Does that mean that that patient's prognosis is worse? He's still the same patient. He still has a negative scan. He still has, he still is the same person we thought of, the day before, but now we have this new knowledge. But his prognosis is probably no different based on those scans. And this is called the Will Rogers phenomenon because Will Rogers made this comment that when the Okies left Oklahoma and moved to California, apologies to the Californians in the crowd, they raised the average intelligence level in both states. And essentially the point is that when you move your metric for what you're testing and measuring, you alter the average, right? So this is a situation where now that the PSMA PET scans are out there, people are going to get them. Doctors are going to order them and patients are going to want them, and that's fine. But we have to be careful what we ask for, because we're going to potentially tell patients that their situation is a lot worse than it actually is, and we might even do that in the other direction as well. Alicia, your comments? You're muted.
Yes, sorry. I realized that. Yes. So I think that I think this is an important concept. I don't know, you don't need to remember the name Will Rogers necessarily, but just imagine if we take all of the highest risk people out of a lower risk group and move them into a higher risk category, the outcomes for the people in that higher risk category are going to be better, because now there are people who have lower risk disease in their group, bringing that average up, better outcomes. And we've taken the highest risk people out of the lower risk group and moved them out of that group. And so those lower risk people are going to have better outcomes, because the high risk people are now removed from their group. But at the end of the day, I think what is important from a medical perspective and what we're wrestling with is that we still have the data that we have. We still have the treatment plans that we developed using less sensitive, traditional, old-fashioned, whatever you want to call it, scans. And so when we're trying to make decisions with people for their cancer, we don't have a lot of good data that tells us exactly what to do based on the newfangled scans. And so we still do rely on our older data. The reason for that is it takes 10, 15, 20 years to get this data, to get the information from all the men who participate in those trials. Those trials take time to mature. So we have to appreciate that, and we have to appreciate the data that we have. And so we try to always do this crosswalk between our newer scans and our old-fashioned or more conventional scans. And sometimes I think that can get a little bit confusing. But that goes back to one of the original points. Just because we have a better way to look at something that's clearer and shows us more doesn't mean we always know exactly what to do with the information. It just tells us we know more, but not necessarily that we know what to do. Now, your doctors will figure it out. They will know what to do. They will come up with a plan. It's not to say that they're completely in the dark. It just means that every bit of data that we have is a little less clear now, just because the imaging is outpacing our clinical trials. But we're getting there, and we're getting the data, and we're working together with patients and with each other to get that knowledge base up. So that's all. It's just a little bit of a gray zone type of a time for certain people with certain stages of prostate cancer, but we're getting there, and we're getting the data, and we appreciate people who are helping us do that through enrolling in clinical trials. Back to you.
Just because you've given him new tools doesn't mean he's a better carpenter, is another way to think about it. I can't get into the questions because I'm sharing my screen, so maybe Alicia, you can go take a look at that. This is what Mike was referring to, and he was referring to an updated set of data. But PSMA PET scans, like I showed you, one end of the molecule binds to PSMA, one end of the molecule creates the image. Long before there were PSMA PET scans, there were a thing called FDG PETs. FDG is the G is glucose, and what we do when you get a glucose FDG scan is you're getting a radioactive little sugar molecule. It's injected into the body, and this is pretty simple. Anywhere in the body that's using a lot of glucose, a lot of sugar, which is cancer, will light up. And so what has been done is FDGs have been compared to PSMAs, and they don't always match up. If you look at the FDGs here, the red, where it says FDG plus, look at the brain, for example. Brain's lighting up because your brain's using a lot of sugar. And the PSMA, the brain doesn't light up at all because there's no PSMA in the brain, okay? So that's one way to tell the difference between those two tests. And so on the left side, what you have is a situation where this person had a PSMA negative FDG positive scan. They had a tumor that was using a lot of sugar, but it wasn't making any PSMA. And then you have on the other side, you have people who were this was eligibility for the Vision trial, by the way, a big clinical trial that just read out. You had people who were PSMA who had PSMA negativity and FDG positivity. But then on the eligible side, the 200% or 200 patients of the 280, I think that there were in this analysis. So roughly 80% or 86% of patients will have PSMA positive disease, and some of them will have FDG positive disease, and some of them will have FDG negative disease. The long and short of it is FDG positive means your cancer is really active, it's eating a lot of sugar and probably growing. So from the prognosis standpoint, it's probably a slightly more aggressive cancer when it's FDG positive, PSMA positive. And I think that the data are settling that out. But this is the point part of the point that what Mike made before. Alicia?
Yeah, so, and I apologize, I was reading the chat, so you may have mentioned this, but an FDG PET is just our old-fashioned PET, if you want to say. That's the standard PET that people say to, I remember being a fellow and everyone would, all the patients that would come in would say, well, everyone I know told me I have to get a PET. Well, that's not the case for most people with prostate cancer, but that is an FDG PET, in case you need to know that. But I wanted to pose a question that came through the chat that is pretty much the crux of the matter. And Amy asked, the question is, if you detect lesions at a very low PSA level, and you've got negative conventional scans or old-fashioned scans, is it necessary to treat them? Especially, is it an indicator to use something like ADT that has side effects for patients? Or is it perhaps maybe better for targeted radiation treatment? What are your thoughts on that? And how do you think through that with your patients? Okay,
so it's a great question because of the following. What that phenomenon highlights is a little bit of the Will Rogers phenomenon, because somebody who normally would not think their cancer had spread now is told his cancer has spread. So now he's going to think his prognosis is worse. That's the bad part. But the good part is that this is an opportunity for innovation. And I think that we need to think about the biology here. What you have is a situation, and my next slide kind of gets into this. What you have is a situation where you have a tumor that's sitting there all by itself, and you can prove the positive. You can prove where the cancer is with this PSMA PET scan. That's really, really good. But you can never prove a negative. You can't prove that it's not somewhere else. And just a negative PSMA PET scan doesn't mean that there's no tumor. It just means that there's not enough bulk of tumor to show up on the scan. And there's a really cool statistic. That's not really cool. It's a statistic I carry around in my brain about the number of cancer cells it takes to form a tumor. And a colleague of mine at Johns Hopkins, Ken Pienta, did this analysis where he basically said, you know, we could take a tube of blood from a person with a rising PSA. They can have negative scans, no tumors, and we can find cancer in their blood, okay? We could do a bone marrow biopsy, just a random bone biopsy of the bone marrow in a patient with no tumors, and we can find cancer cells in the bone, in the bone marrow. Then through a series of sort of mathematical exercises, they figured, well, that blood test is 7.5 milliliters. The average male has 5 liters of blood. So if you go one cell times 5 liters of blood, you can have, you know, however many millions of cells floating around your body and not have any tumor. And so anyway, they basically did this calculation and found that I think you have to have, I think it's 2.1 billion cancer cells to form a tumor that shows up on a scan. So that's interesting, because what it also means is you could have 1.9 billion cancer cells floating around in your body and not have anything showing up on the scans. So how does this get to Amy's question? Well, it gets to Amy's question because of the following. At some point, there is a point of no return, if you will, where the cancer was the fish in the barrel, right? It was in the tumor, it was in the prostate, or maybe just in the lymph node. But at some point, that number, that critical mass, that population of cells circulating in the body gets to the point where it starts to spread to other parts of the body. And then that becomes a systemic disease. Systemic disease is a very different thing than focal or localized disease. So the focal or the localized disease that might show up on that one lymph node, if all of the cancer's in there, yes, we should radiate that. Yes, we should maybe remove that with surgery. And I have seen in my career a few cases where we've done that, and we've been really lucky and successful because maybe all of the cancer in that person's body was packed into that one tumor. But I think most of the time it's not, unfortunately. And this is the critical thing, which is we just don't know the moment where it goes from, yep, it's all of the fish are in the barrel, to some of the fish are out of the barrel. We just don't know when that happens. And that gets to what happens here, which is a really interesting also data coming from Johns Hopkins, where they think a lot about this topic. This was a paper in Nature, which is, you know, the leading science journal really in the world. And what they did is they took patients, they had patients who had died of prostate cancer, and they took the prostate, they took a bone metastasis, they took a lymph node metastasis, they took other bone metastasis. And what they showed is that some of the metastases, the spots that showed up in the bone or the lymph nodes, were genetically identical to what started in the prostate. But in some cases, things went from genetically identical in the prostate to a genetically identical spot in the bone. And then the next one was genetically different from the first one. So what happened is the cancer spread, it's the same, okay? And then it's and then over time, it changes and it becomes different from where it started. So the way I think about it is, you know, somebody immigrates to the United States from France, they're going to speak French. Their kids are probably going to speak French, but their grandkids probably aren't going to speak French. And so that's kind of a way to think about it. As these things migrate, they evolve and they adapt to their new environment and become genetically different. I got us a little off track with that question, but I think we're kind of on the right track in terms of the overall theme, right, Alicia?
Yeah, I agree. So maybe, do you want to go back to, I don't know if you wanted to say anything else about imaging, which is part of the workup for metastatic CRPC, and that's what we're talking about, the imaging advances.
Yeah, I'm gonna make one other quick point, and then we're gonna talk about genetics.
Yeah.
So the pattern of spread is also really important. This is some work done by a colleague of ours, Susan Hollaby. And when we talk about metastatic prostate cancer, we sort of talk about it like it left the prostate and that's all the same entity. And that's actually not the case. Somebody whose cancer spreads to their lymph nodes, that's a much better situation, a much better prognosis than if it spreads to the bone. And the bone is much better than, for example, if it spreads to the liver. Now, this is, you know, one way to look at it. We're going to talk about the other way to look at it, which is biologically, but from an imaging perspective, not all metastases are the same. All right. Alicia, we're going to talk a little bit about genetics versus genomics. I wanted to just sort of put this out there. You know, we're going to first talk a little bit about the objectives of why we would do genetic testing and all of that. But if you could just, you know, give a little introduction to what do I mean when I say genetic or genomic testing?
Okay, well, so there are, I think everyone remembers from science class that the basic building blocks of what makes us is our DNA. It's basically the code book that tells each of our cells what they're going to be and how they're going to come together. And the DNA that we have in each of our cells is something that we inherited from our parents. We get half from our mom and half from our dad, or half from the egg and half from the sperm. And that's what makes you a complete person. And there can be changes in that DNA that you've inherited. And that change can occur in one place. Typically that's where it would occur, but it could occur in one place in the cancer and then become a cancer just around this one cell that was in the prostate that just sort of tried to duplicate itself, but made an error, and that error stuck around and the cell still was there and it duplicated itself and it duplicated that error. And when it does that, that is what we call a somatic mutation or a genetic mutation that's only in the cancer cell.
I'm gonna just forward to some slides that show this.
Okay, and if there's a mutation though that we got from our parent, we could potentially pass that mutation on when we have our own children, and that's something that we've inherited and we could pass on. That is in something called the germ line, which is basically the line of ancestry. something that happens in the tumor only doesn't get passed on to anybody. Something that happened from our parent and came to us or started in us and was passed down to our offspring is germline. Something that's only in the tumor is somatic. We can't pass on things that are only in the tumor. We can only pass on things that are germline. But basically these things that I'm talking about are mistypes, misprints in the code book. They're mutations in the code book. They're mistakes. And those mistakes give an opportunity for a cell to become a cancer, which essentially means that the cell has a broken piece that lets it live forever and leave its home and spread. And that's what cancer is. So, so these things that we're talking about, germline genetic mutation or somatic genetic mutation. Somatic is what happens only in the tumor. Germline is what we may have gotten from our family and may pass on. Just two different ways to get a mutation that can cause cancer, or a mistype in the code book of our DNA that can create this immortal cell that can be cancer, and it can grow.
When do you want to start looking at this in a patient in your practice?
So right now, the guidance on this has actually changed over the last couple of years. And any patient who has prostate cancer that's spread outside of the prostate is a patient who should be getting that germline genetic testing, what you've inherited and what you could pass on testing, to understand if the cancer in that person that has now spread is from a family member. If it is from a family member or is something that the man who has the cancer can pass on, it's important to know that, because that is something that he may want to talk to his family about, his children, his brothers and sisters, because his female children are at higher risk of having breast or ovarian cancer. His male children or his sons are at higher risk of having prostate cancer. And they're all potentially a little bit higher risk of having pancreatic cancer and perhaps some urinary tract, bladder type cancer. So, so understanding that is important. Anytime a patient has metastatic cancer, prostate cancer, we want to check for that inheritance type thing. Actually, that's true now. These guidances have changed. Even if patients have cancer that's still all in the prostate, but it's very high risk, these people also should undergo that germline inherited type testing. So we also, especially when patients get metastatic castration-resistant prostate cancer or this rising PSA, maybe growing cancer, even when testosterone is low, those people should also get somatic testing to understand the DNA or the code book inside the tumor itself, because that might give us a target for treatment of that cancer. And that inherited type of mutation can also give us a target for treatment of the cancer. So two different ways for us to potentially get targets to treat the cancer. And that may have been roundabout and convoluted. So maybe you want to say that in a shorter punch phrase.
A shorter punch phrase? No, I mean, mom and dad, germline, tumor tissue, somatic. And the other thing is, I brought up your slide on where you're getting the tissue from. And I think that it's also important to know that, that we have a lot of testing types. Some of them are require a biopsy or the blood DNA from the tumor. And there's a couple of interesting things to go through here. So if you want to look at the germline, you don't obviously anybody can do that. It doesn't have to be a cancer patient. You can do a cheek swab and send that in, and there's many of those types of tests. I think people understand what a biopsy would be, but I also think that it's important to know that, let's say, for example, you had your prostate removed in 2012. And let's say here you are in 2021 and you've been treated and the treatment's no longer working and your doctor wants to look at the genetics of your tissue. Well, your doctor can go back to your prostate that may still be in the pathology department at the hospital where it was done, and they can do a genetic test. And that may be very helpful, okay? And maybe all you need, maybe really helpful. But the other thing is, think about it. The cancer cells that are in your body today, they've been in there for 9 years. And they've been evolving and they've been adapting to the treatment, and they're probably different. And it gets to a little bit of my analogy of, it's a few generations later, they may not speak French anymore. And so getting more accurate information from the testing today is actually something that is doable through a biopsy of a metastatic site, which could be hard because that it might be they have to drill into your pelvis or to your spine or to your femur or something like that. And that may cause pain or may be just challenging to do technically. So there's a lot of promise in looking at blood-based tests for somatic testing. And that's what this really nice diagram shows is ctDNA, is circulating tumor DNA, or CTC testing. And I think nowadays there's a test called the Guardant 360 test, for example. That is a circulating tumor DNA test. All of us, whether we have cancer or not, have DNA in our blood because our bodies just make so much DNA that it just kind of comes out of our cells and circulates around. Those with cancer actually have some of their circulating DNA is circulating tumor DNA. It could be 1% of their overall DNA in the blood. It could be 20% or even higher. And when that's there, they can do the same test on it to look for mutations. And so if we're working you up, which is the theme of this session, that would be one way to do it. I think that it's still not as good as doing a tumor biopsy, because the one thing we don't quite understand is if there's DNA shed into the blood and circulating tumor cells, are those things that are in the blood, do they accurately reflect what's going on in the tumor? And there's really no better way to know what a tumor is, what's going on in the tumor, than to get the actual tumor. So this is fascinating. I just want to say there's one other thing that's going on. I just came back from Los Angeles today, where yesterday I was in a conference, the Milken Institute Global Conference, and there was a panel there on a blood test now that's looking at circulating tumor DNA as a screen for cancers. So healthy individuals without cancer can go and get a blood test, and they might get a report back that says you have DNA that says you have pancreas cancer, and it might be they have no symptoms, and they could go in and they get a scan. Now I'm kind of excited about this, but I'm also kind of worried about it, right? Because this means people could go in and think they have all kinds of different cancers, and that could lead to workups. And we haven't yet shown that that's beneficial to the individual or to society. So there's a little bit of a reason to be kind of conservative on this. But I think, and I'll kick it back to Alicia in a second, but there's really two reasons, Alicia, that are very actionable today for us to be doing DNA testing, two therapeutic classes that we want to think through. And I'll let you talk through that, and I'll bring up the slide to cue you on that.
Sure. So, actually thank you. That's a nice slide. So what this slide shows, this pie chart on the right, is a bunch of different mutations and the frequency with which we would find them inside a prostate cancer, in prostate cancer patients. That big gray area on the left, 44% of the time, is something called BRCA2. And BRCA1 and BRCA2 are two mutations that can cause cancer syndromes. You may have heard, I don't know which one it was that she had, but you may have heard of Angelina Jolie having prophylactic mastectomy. So she had mastectomy before she had breast cancer. And it was because she had one of those BRCA genes that she did that. So those genes can cause prostate cancer, but they also can cause breast and ovarian cancer. So I think it's important to find this, because whether you have daughters or sons or sisters or brothers, if you have that alteration, each of those people who is 1 degree relative to you actually has a 50% chance of having that alteration too. So if you have it, they may have it, and they may benefit from getting tested, because that may mean that they need different screening patterns for them. So BRCA2, most common. It's also, to get back to the point that you were trying to get me to make, it is also targetable by something called a Parp inhibitor, which is a treatment we'll get into in a few minutes, but this is a targeted therapy that can cause cancer cells to self-destruct as they're trying to grow and cause trouble. It is the most common, BRCA2, and it's also, we think, probably the most sensitive to treatment with these Parp inhibitors. So that's good.
I just want to
other alterations that we can see sort of up in the upper, like 11 o'clock, if that was a clock. MSH2 and MSH6, these are alterations that can be in a different syndrome called Lynch syndrome, which is associated potentially with some other cancers, including upper tract, bladder type cancers that are closer to the kidney or in the tube between the kidney and the bladder. It can also cause some colon cancer. So this can cause some other types of cancers and would be important to also test in family members, but may give an individual an opportunity, a patient with a cancer with that mutation, to be treated with something called pembrolizumab, which is an immunotherapy that is trying to target and shut down dysfunctional immune type activity in these patients. So I think this is where we were trying to go. I think that these mutations are present in different amounts in cancer tissue, for prostate cancer tissue. And there are some of them that, if we can find them, may give us good options for treating patients, but also have implications for our family members.
I want to point out on this slide, this is not 100% of patients. This is germline mutations, or mutations that are frequently seen in prostate cancer. Of the mutations that are pathogenic, that participate in the disease, 44% of them are BRCA2. That is not, we did not mean to imply that 44% of prostate cancer patients have BRCA2 mutations. In reality, it's only about, maybe 10%. or so.
Yeah, just to be clear, you can see this, first of all, this is only in metastatic patients, this particular trial. And the overall, for all of the things in that pie, they came up with just under 12% of people had one of the things in that pie. So, no, I'm not saying that 44% of people with prostate cancer have that mutation. That's among the mutations that they found. 44% of them were this particular type of mutation.
Right.
Most men with prostate cancer do not have these, but when the number is over 10%, that population qualifies basically for this germline genetic testing. And that's why this study was important, because it's over 10%. And so that's why we actually, the genetic counseling community thinks that it's important for us to test. And we find enough of these people because there are so many men with prostate cancer in the world. And so we do find a lot of men, and we are able to treat them. Back to you.
This is a graph that I've shown several times over the years. This is a PSA graph of a patient of mine from California, and he had a prostatectomy, and then he developed metastatic disease. I treated him with hormone therapy, I treated him with chemotherapy, I treated him with Zytiga, and finally his PSA got up into the 160s. And he, like the example that I gave before, he had his prostate removed, and it was still in our pathology department. So I went and I had it ordered, and I did the genetic testing. And what I found out when his PSA was up here at 160, I found out that he had an MSH6 mutation, and he was one of these MSI high patients. That's only about 3% of the whole prostate cancer population. But this is why it's so important to know, if you have this, is that this was a person who had a PSA of 161. He had bone pain, and he was beginning to slow down. I did this test. He had this thing, this mutation in MSH6. I called him up. I brought him in. I started him on pembrolizumab. And look at what happened to his PSA. After one dose, it dropped to 20. After 2 doses, it dropped to 4. After 3 doses, it dropped to, I think, undetectable. We treated him for 6 months. And look at the date. I started him August 13th of 2017. I'm still in touch with him. He still emails me, sends me pictures at Christmas, etc. He is off treatment now. And that is an incredible story. One of the most gratifying stories in my whole career, because he would have died probably by Christmas of 2017 if I hadn't done this test and if that drug hadn't been available. And so this is why you need to know if you are MSI high or not. You're most likely not, because 95% aren't, but the implications are so great that it's worth knowing. And that, I think, is something that is just a key driver of this decision. I'm going to go back to one of Dr. Morgan's testing. Is that we think everybody should be having genetic testing if they have developed metastatic disease, if they have CRPC, but keep in mind, it doesn't always lead to a new therapy. It doesn't always lead to a drop in the PSA as dramatic as that patient's. And there's also a whole host of these tests that need to be done, and they have their technical limitations as well. Alicia, any comments?
Well, I think you kind of summed it up. I mean, essentially, this slide just really talks about we have a clinical question. Is there something targetable? And in metastatic CRPC, this disease state, there are drugs, Parp inhibitors, olaparib and rucaparib, that are approved for treating this stage or type of prostate cancer. Pembrolizumab is also approved. And so that's why it's so important to get these tests. You can see the things that docs think about. Okay, we have a question. What's the next treatment for this patient? We have to choose our test. Are we going to do germline testing with a blood test, or are we going to do a cheek swab? We could do a home kit. Are we going to do it in the clinic? That's a relatively easy one. But the harder one is maybe, do we need to do another biopsy, or can we use the prostatectomy specimen and just send that? Because most of the mutations that are targetable with olaparib and rucaparib are going to be present in that initial prostatectomy specimen for most people. So they could send that if they can't get a new biopsy, or they could decide, do we do a circulating tumor DNA blood test and try to do that? Although that is easier, maybe it is not necessarily as validated as the tissue test from the prostatectomy or from a metastatic biopsy. So that's kind of what we think about. And as we heard, we don't always get a positive. In fact, in most cases, we do not get a positive. But if there is a positive, it could have implications for treatment. And remember, family as well.
So we have a few questions, and then we have about 15 minutes left. I'm going to make tell one more story about genetic testing, and then let's do questions. So can you look through the questions while I do that?
Yeah, we've been answering them, but go ahead.
Okay. I just wanted to point out that this is a slide I've gotten from Karen Knutson over the years, and you'll hear this topic brought up a lot with this aggressive variant of prostate cancer. And I get a lot of calls from patients worrying, do I have the aggressive variant? Have I gone neuroendocrine, or do I have small cell? And that's something we really haven't talked about a lot. But this is part of that idea that the cancer over time, if you have this disease and you have your several billion cancer cells, and they're the normal type of prostate cancer, but maybe 1 in a billion cells are the neuroendocrine type, and you treat people over time, you give enzalutamide or abiraterone or chemotherapy or whatever, over time, the cancer can change, the cancer can evolve, as is shown here. And one of the reasons why I bring this up is that this is something where if you're testing over on the left, when most of the tumors are the red triangles, you're going to see a normal traditional looking prostate cancer. But if you're testing years later, you're doing that biopsy years later, when the cancer has evolved, you're going to see more of the evolved cancer, and you're going to get a more contemporary picture of what's going on with the cancer. Now, that's not always actionable. And I show this picture for these three letters, these three mutations called TP53, RB1, and PTEN. Very complicated biology here, but these are 3 mutations that seem to show up together sometimes. And they are the 3 horsemen of more aggressive prostate cancer. And we've written papers on it in my group, and others are exploring whether we should put patients with this constellation, this triad of mutations on chemotherapies. And it would be good to know as a patient, yes, you should know, do you have a DNA repair mutation? Should you get a Parp inhibitor? Yes, you should know if you have MSI high, should you get an immunotherapy? And yes, I think you should know if you have any of the subtypes of this aggressive variant. If you're in my clinic and you're in shape enough to do it, and you show up with these mutations, I'm going to give you platinum chemotherapy. I'm going to give you a drug called carboplatin with your chemotherapy, because many studies show that it helps to slow down the spread of the cancer and put the cancer into remission. Myself and actually Alicia are leading some clinical trials looking at this phenomenon as well. So this is a situation where it's not exactly actionable. Like, it's not like, oh, we have a drug for that, but we kind of do. And we treat it differently. And we can tell you more honestly if your disease is in this aggressive variant. And so the final point that I want to make about all of the genetic testing, and I think it's even a point about the imaging, is this point I kind of started out with, which is saying, more knowledge is usually better. I think it is. I like to know what the genetics are of my patient's tumor. It informs me. It helps me to tell you, oh, you don't have the complicated mutations. This is very favorable. Or, oh, you do have the more complicated mutations. This is going to be a more aggressive case, and we're going to try to fight it with, we might have to use harder treatments or more intense treatments. But the other way, I want to just point out, I have a close friend who has metastatic prostate cancer, my same age, and he's gone through chemotherapy and hormones, and it's been kind of interesting having somebody who I've known for years as a friend have this disease. And he got his tumor sequence, and he had what was called an SPOP mutation, SPOP. And there's just a paper in Science, one of the leading journals in science like Nature, showing that SPOP mutations make the cancer more susceptible to hormone treatments. So it's actually a mutation that may actually be a good thing, a good sign for hormone therapy. When he was telling me this, I was like, oh, that's one of the kind of the good mutation, good prognosis mutations. So this cuts both ways, right? Most of the time when we think about mutations and we think about genetics, we're trying to look for something that's worse. But in some cases, we can get reassurance. When I get a genetics report, genomic report back from a patient's tumor, and I don't see a lot of mutations, I think, this tumor is going to respond perhaps a little bit better to therapy, as long as I'm trusting that we got a good test. So that's part of us knowing more. And hopefully knowing more will lead to knowing better. And hopefully knowing better will lead to us being able to treat you better and future versions of you. And I think that that's a key part of why we're gathering all this information at this time. And I'll stop rambling because, Alicia, I'm sure you have some really good points to make.
I actually just have some questions and some clarifications. So one I think is an important one from our friend Rick Davis, who just reminds everyone and reminds us to remind everyone. I showed you that pie chart. Can you put that pie chart back up there, please?
Yeah. Yeah.
So you could see on this pie chart that there are tons of different alterations that are conceivably what we would call actionable, maybe targetable with medicines like olaparib, for example, a Parp inhibitor, a targeted therapy that's supposed to sort of interrupt the DNA replication or the copying of that DNA code book. And if it does interrupt it, it can make the cell self-destruct and die. BRCA2 is very vulnerable to that Parp inhibitor coming in and messing things up. But olaparib, which is a Parp inhibitor, is actually approved to treat a number of these things around the pie. And not all of them actually are so sensitive to treatment with olaparib. So it is important as you are talking to your doctor, if you have one of the other mutations, maybe an ATM mutation or a CHEK2 mutation, or even a CDK12 mutation, to understand what all of your options for treatment are. Because if that's a mutation that is maybe sensitive to treatment with olaparib, but has a higher chance of not being affected by olaparib, you might want to choose a different treatment first, and then kind of have olaparib on the back burner. Whereas if it's a BRCA2 alteration, mutation, maybe you want to go right for that Parp inhibitor. Not all mutations are created equal, essentially, even if they're covered under the FDA approval for the medicine. So I think that's a good and important point. One other point or question that is raised that I think is just important for you to comment on related to imaging: why would something show up on a PSMA PET but not show up on an MRI or even an Axeman scan? And what's the difference from your perspective on between PSMA PET approaches and Axeman PET approaches?
Yes, the Axeman PET and the PSMA is a molecular targeted therapy. So you're looking for a target on the cancer cell. The Axeman and fluciclovine, these are sort of metabolic tests that have a radioactive form of a molecule that is used by the cancer. And the bottom line is it all boils down to the specificity, really, like how much of the cancer actually expresses this finding. And PSMA is the most sensitive. It's as Mike stated early on, and we showed about 86% of the cases have the PSMA molecule on their surface. And it's more sensitive also in that you can have a smaller tumor. And that's the point. When you look at these scans, and I could bring one up, but on a CAT scan, sometimes the tumors are so small that that they don't show up because that's a black and white two-dimensional picture. But the PSMA PET scan gives it this halo because it turns the lights on really bright. And so that allows it to be more sensitive. Again, it gets back to my issue. You're flying over a city at night. You might see the big buildings even in the dark, but a small building with a bright light, you're going to see.
So just to really clarify that, because I think that's a great point, an MRI, a CAT scan, a bone scan, these are all black and white pictures. Unless something gets bigger, if it's just inside a lymph node, but it's a couple cells, or it's inside the liver and just a couple cells, it's not going to be visible because it's inside, it hasn't changed the shape, and it all looks black and white. But when a PET scan is used, it actually lights up with a radioactive, the computer changes it into pretty colors, but it essentially is a radioactive material that the computer interprets as a different color. So here we can see it's lighting up red. So you could, the PET part is the reddish yellow part, and the black and white stuff is a CAT scan. So we take a PET to show the activity and we put it onto the anatomy or the shapes of the body on the CAT scan. So that's why it's called a PET CT. We have to use them together. Otherwise, we don't put them together. We see floating balls of light in the middle of nowhere, and we don't know what those are either. So you have to put it onto the anatomy of the CT scan.
But the other point is, this is a person who had a negative CAT scan and a positive PSMA PET. And you look at this and you're like, wow, there's these two really big, really bright tumors. But the other thing is you can't really ascertain the size of the tumor based on the brightness of the light, on because there's a halo effect. That brightness is a little bit bigger than the actual tumor. And so it's bright, it's good to see. And that's is an interesting case of mine. This is a person who has a P10 mutation and CRPC, and we did this scan, and these are the only tumors we saw in the whole body. And
can I ask you, here's a question. Sure. It's about the utility of this. So for example, pretend this was an Axemin scan. So Axemin is just a different type of PET. So it's going to light up in a very similar way. It's just not using the same protein. It's using a transporter essentially to come into the cell. It's like a cell activity thing, more like sugar, the FDG PET. It's more similar to that. It just is a different mode. It's a little bit different, and it's not quite as sensitive. That's the bottom line. It's not that it's bad. It's actually still very good, and it's better than a CT scan.
It's useful. The PSMAs are probably better.
Yes, more sensitive. Just means they pick up things a little bit earlier. Yeah. But in any event, pretend this was identified on Axemin because it could look very similar. How do you make a decision about whether you would use a targeted radiation to something like that, or whether you might start a treatment that's a medical treatment like ADT?
Right. So this is a patient of mine, and so this scan was done, and these are the only two sites, the only two tumors in the whole body. And he's a big guy, and I had already done a sequencing analysis of his tumor, and I knew that he had a high risk mutation. And so I knew that he had a mutation where usually when I see it, I want to give chemotherapy. And then I thought, well, but this is strange because it's not really widespread. I wonder if I can get these two spots out. So the reason I have this picture sitting on my desktop is I actually showed it, I've saved it, but I showed it at our tumor board, because in our tumor board, we have radiation oncologists and we have urologists there. And I said, hey, you guys, can you go in and take these tumors out? Urologist said, well, he's already had radiation in his pelvis. He's already had his prostate out. That'd be too risky. And he also said something that's really honest and really important, which is, he said, I don't think I could find this. Like this shows up so bright on the scan, you think it's a huge tumor. But when you go in there surgically, they're not exactly sure if they can find things, because they're not operating in a CAT scan. They're operating in a body with 3 dimensions and all of that. So that was sort of an interesting perspective. And then the radiation oncologist looked at this and he said, well, easy to radiate, 2 little spots, he said, but that organ sitting right next to it, you got the bone there to the screen stage left, if you will. You got the hip and the pelvis. And then as you go towards the middle of the body, you have the large bowel, the colon. And he said, well, I could try to hit that with radiation, but that's so close to the colon, I would be worried that that I'm going to hit the colon, and that would cause problems. It could, cause blood in the stool or even colon cancer or other things.
And nausea, diarrhea, it's not pleasant. You don't want to radiate the bowel.
But the types of radiation they use in these cases is a stereotactic body radiotherapy. So it's usually a really focal dose of radiation. So I then sent this picture to another colleague of mine, radiation oncologist, who said, "Oh, sure, I think I can do the radiation and I can miss the colon." And it's a good case of the surgeon saying, "I don't think I can find that." So, being honest, one radiation oncologist saying, "I don't think this is safe," and another radiation oncologist saying, "Oh, sure, I can do this." And so these are technologies that have human interpretation. And we're now having a lot of conversations like that in this era because we have this new imaging technology, but it's still interpreted by and actioned on by human beings.
So, Dr.
Great. So
Ryan,
can I ask-
might I just ask a quick question about this?
Sure.
Do you believe that the availability
That
of
shit is not like 1, 2, 3.
lutetium
If you have a
177
customer come in
PSMA?
that case, and I'm almost be willing that I don't know if they're going to still be able to get the promotion. These people are telling them this shit on the phone, and then they come in here.
All right, I'm going to
I'm
ask.
sorry, Dr. Ryan. So my question is, do you believe the use of lutetium 177 and the actinium equivalent that are PSMA targeted could affect the treatment of a man like this?
Well, maybe. Here's the problem with the answer is I bet lutetium would certainly find lutetium PSMA would find this lymph node and would probably eliminate it. The challenge that I still don't get a good answer on is I feel like I would be putting a whole lot of radiation into this person's bone marrow just to hit these two lymph nodes. Whereas if I could just do radiation to just those two lymph nodes, I might not flood his entire bone marrow with lutetium 177. So while the lutetium data is really, really compelling, and it is going to become a treatment, and I will use it, I do worry a little bit about high doses in low disease volume. And some people say that's not a problem because we adjust the doses and it shouldn't be a problem. And other people do have a concern about, other people who study nuclear medicine do have a concern about it. So that is another area where there's just a little bit of work that needs to be done on our interpretation of this.
I want to ask you I'd like to ask you another very pertinent question, and I appreciate your comments on lutetium. The other thing is we actually don't know if lutetium would eliminate that. We're I think much more, our understanding of targeted radiation and kind of just burning those things to death with a targeted radiation is actually much stronger than our understanding of lutetium at this point and how much it can do at any one spot. I think we have a lot to learn there, but this is very practical and a brief answer, please, Dr. Ryan, because we're at time. Patient is wondering, PSA has reached 0.26, 2.5 years after prostatectomy. When would you think about getting a PSMA scan?
Great question. 0.4.
All right, thank you for answering that. And then I'm sorry, I think we are at time, so I wanted to hand it back to Mike because I don't want to take.
This has been a very difficult topic to deal with, and I was very aware of that in the beginning because so much is changing so fast. I'd like to thank you both so much this evening for giving so much time. I know you're both very busy people. I hope we've at least provided patients with more knowledge about the questions that they can bring to their own doctors. And hopefully we will be able to continue to find new forms of therapy that can treat late-stage disease like this in the near future. And Dr. Ryan now has control of the purse strings to help that happen.
Total control.
So thank you very much. And I'm going to give you back to Jamie, who will close us down.
So I just want to thank you all for your time this evening, and a big thank you to our presenters, Dr. Ryans and Dr. Morgans. And appreciate all of our participants. Please do not hesitate to reach out to cancer support community if you are in need of resources or support for prostate cancer. Thank you all and have a good evening.
Thank you.